leadership that is in the room, Deputy Minister. My name is Baphelele Mhlaba. A few minutes ago, I was put on the spot, and somehow I feel the need to respond without taking too much of your time. It would be inappropriate for me not to respond when the Deputy Minister speaks. I work for an organization.
Expensive because they're capex driven predominantly, and the affordability of medical supplies. These are some of the things that makes that curve to grow significantly without the concomitant improvement in healthcare. These are some of our view from our own analysis. But therefore, you can therefore say, actually, healthcare delivery in the country has an inflationary impact in the economy. So it continues, the cost continues to increase. However, the improvement in healthcare, though there is progress, it's not at the quantum that is concomitant with the increasing in budget. Healthcare budgets is a second highest to education, so it means it's significant. How then do we use the same budget to improve and also improve the health outcomes significantly? This is what I think today we need to be discussing in the panel. It's moving very fast. Of course, technology will revolutionize how healthcare is delivered. So how it's delivered, how it's financed, and how it's managed. So especially mobile healthcare, and these are some of the opportunities we see in the evolution of mobile healthcare in particular, where we're no longer talking about big systems, we're no longer talking about large infrastructure that's capex that you have to take a big bet to buy and make a decision on. We can talk about simple solutions carried off your mobile that is able to deliver monitoring and early surveillance in the healthcare system. So I'm trying to run a bit very fast just to understand the context why we're talking about this today. So if we move on, so what are the driving forces then of the healthcare revolution? Cloud computing, which means scalable multi-tenanted service systems that are able to be built once and be delivered into different locations using different types of access. So instead of buying different servers, different systems all over with cost, with maintenance thing, you have one big super system that is able to give you the kind of computing capability that you can get spread across different locations. So again, the spread of mobile broadband technology, we are investing consistently across the country to improve the networks. LTE, 3G is going to be reaching far-flung rural areas, but spectrum decisions must be made quicker so that even rural areas are able to benefit high-speed broadband mobile networks, smartphone penetrations, and tablets. So we're pushing every year that the low-end smartphone must continue, the price must come down so that even rural areas, even the people on the different strata of the economy can afford to have smartphones, not only feature phones. These are the things that are driving the adoption of healthcare technologies in the world. And again, the adaptable medical transducers. Whereas in the past, a stethoscope had to be monitored by somebody in the doctor's room, but now a stethoscope is repurposed through Bluetooth technology to talk to the mobile phone and be able to shoot through the trends, whether it's a cardiovascular technology or blood pressure monitoring or just hearing or eye screening, you're able to integrate to a smartphone, which means the doctor doesn't need to be in the room. It could just be a basic community health worker who sits there with low skills, and then you have your clinical professional sitting here in East London or Johannesburg, be able to actually pick up the trends and highlight the key warning signals and say that patient must come to the hospital because I think the early signs, instead of allowing the person to degenerate and then it becomes a bed occupied and it drives up the cost of the healthcare. So this is what we are talking about. These are the drivers. So it's possible, it's doable now. Again, let's make progress. We spoke about some of the key challenges we are facing in South Africa. 17 million people earning grants, which means these people are likely not to afford their own medical care, which means they rely on government. So how then government address the healthcare of this population becomes very important. Cost-effective ways and being able to deliver it in a smart way because it's not going to change. So we need to be smart in how we deliver healthcare. And again, the shortage of doctors in the country continues to be a challenge that we need to address. So I'm framing the reason why it's now that we need to do something, because all the signs are saying do something, all the possibilities are there. What is needed is willingness, is commitment, is boldness to say, let's go beyond thinking that it's there, it's beyond pilots, it's available now. So that's what we're talking about. So if you look at the healthcare system, ecosystem on its own, so you've got patients, citizens as beneficiaries, you've got health, health, that is the paying members of the health in the health system. You've got medical insurance providers, government as a sponsor in terms of the public health care. Again, you've got institutions. These are private healthcare providers and the public healthcare hospitals. There's an interest to make sure that the bed occupancy is quite low. Rudy, I'm going to finish now. And again, the health outcomes that we desire, it's clear, successful, good health, successful health outcome, and so on. Let me just move quickly. I'm about to finish. Now, I spoke about the ecosystem. There are actors there. Every actor has an interest to optimize for themselves in the system. Citizens want good health. They want to spend less time in hospital. They want to be healthy. So that's good interest. The healthcare insurers, they want to make profits. If you pay medical aid, they want you to be healthy so that you don't, they have, you see, the profits in healthcare system is a difference between premiums and the claims. So as you pay premiums and you don't claim, then they bank it, they make profit. So there's interest for a healthy lifestyle. So patients want to be healthy. Medical providers, the healthcare insurers wants you to be healthy for their own selfish interests. Again, the healthcare providers, be it private hospitals or public hospitals, they don't want you to be sick because you are a cost to them. So everyone has one interest of saying a better healthcare. Yet, to facilitate this common interest, you need systems, you need processes, you need mechanism through which access to specialists is done seamlessly, even if you are living in a very rural area. So my last position on this is that what the technology is doing, the healthcare technology, mobile healthcare technology is shifting healthcare, how healthcare is administered. Whereas today it's largely in doctor's room and in hospitals. We're moving it to the home, to the retail environment. Anywhere you can be monitored as long as there's technology. So it's going to be available anywhere and anytime. And that's the crux of the matter. You do not need to be in a clinic. You do not need to be in a doctor's room to have access. You can be in the home and have all these devices that monitor, and they link you up to your doctor. So let's go to the video that we want to play, Rudy, and then we close from my side. So I guess the message is the technology is ripe for picking. It needs us to exploit it. Whereas in America, it's more about innovation because they have got a reasonably good healthcare system. Ours in Africa is instructive. We have to do it. We don't have a choice.
Feel and respond to healthcare. Welcome to the next generation health, powered by Vodacom.
Almost by invitation, if you look at the exhibition we have downstairs, we have all this, it's real. you have a baby monitor that streams in. You can feel the heartbeat of both the baby and the mother, which in rural areas it's probably not affordable. But when you have this technology, all of a sudden at the home, in the clinic, it's affordable. So the healthcare delivery can improve significantly at a very low cost. That's the issue. The issue is the cost of delivering technology on mobile is very low in terms of healthcare. So that's kind of our view from Vodacom. We are committed to invest in this area. Thank you very much. I know it took a bit longer than I should have.
Thank you, Players. You can actually take a seat. At some stage there, I actually thought that you're no longer Vodacom. I was beginning to hear other things that we should be saying, not you. So it's going to be a very interesting conversation to hear how the head of department from the Eastern Cape Department of Health, to hear how he actually responds. Can I quickly call up my panelists? They quickly know who they are. Mr. Jacques DeForce, HOD, please make your way, come. Dr. Kamlash as well on seat next to you as well, please come through. I thought I saw you there. Please come through. And Dr. Bakri. Please don't say what I'm saying. You're not allowed to make that comment. It's quite obvious. Where's Dr. Bakri? Okay. I'm at least told that she is not here. I did not allow you to make a comment. You do have your programs in front of your colleagues. I'm not going to read out which, or rather what is the title that each of my panelists have, because in all honesty, all pieces that I hear are not just listeners, but they are true listeners. And I hope someone is able to find the wife, or rather the wife, that we're busy looking into. And from the last session, I did learn one new word, which is to dive into things.
Yeah.
So I'm gonna quickly dive into a rather unstructured manner of responding. There's a mic that I have in front of you, colleagues, and I'm not gonna be the one that steals the limelight. I'm gonna give about 5 minutes of each of my speakers, with the exception of the HOD, and by the power that I've vested in me, I'm gonna give him 6 minutes. Just a little bit more than what you guys have. And then the topic is quite rather very clear, and it has been placed on the program, and I know that you've well prepared for it. So we're going to take a manner in which, or rather we're going to take some time and give you time to respond, and you have your time, HOD.
First, let me greet the Deputy Minister and all the colleagues. I think the MEC for Health would have loved to be here. I primarily represent her. I think for me, really, this has been very important in many respects, and I think the question has been raised: what is it that the technologies can do for healthcare services? The greater sense is that when you think about healthcare services, we are actually confronted with three basic problems. One is really the demand of the healthcare services, which has actually been growing quite substantially. This demand is driven by both the disease burden, but the expectations of citizens for a better health and a more responsive system. On the other hand, we are also confronted with the supply of healthcare services, which is actually very costly, and that's actually been growing, and the costs actually are outstripping the outcomes that are actually there. But more importantly, that's related to the demand and know exactly how to really best position yourself to make the very difficult decisions where the resources go, where you can get the best outcome in the healthcare services. We see this whole discussions on the ICT as very central then to support and actually resolve those problems. What are the real things that are really we want to focus on? I think everyone is very aware that the NDP 2030 has made very high goals and set very stringent targets and expect a high level of performance between the next 15 years. Many of those goals actually requires that every South African by 2030 at least achieve an age of 70 years, and that we reduce the under 5 mortality to less than 20 per thousand live births, under 1 mortality less than 15 per live birth, and most importantly, start to respond to a bigger problem of lifestyle and non-communicable diseases, hypertension, diabetes, and cancers, and all those kind of issues, and reduce these by a factor of about 25% between now and then. We are also facing a much bigger problem of not having fully recognized and resolved to all the MDG problems that we have faced, especially MDG 4 and 5. So we've got a big problem of HIV. We're one of the most expensive programs in the world for HIV, where we actually have 3 million people on treatment. We consume over 25% of the world's drug production, and all these people will probably live for another 30 or 40 years. For them to continue adhering to medicines, we need systems that are going to support us to achieve that. ICT is very important. Let me just go back to the province as we conclude my point. I think if you look in all the promising aspects of the ICT, one of the most fundamental issues that's constraining us is the availability of connectivity. ICT is like the R61 between Umtata and Lebode. You must have a very strong ICT system. I think it's very important for us, we should build onto that. And it's more important for the province because if we have to create the coordination and actually reduce the cost of doing business, we need to actually deal with that. The second biggest area is really patient records. We have made some very good strides in actually doing this. We insist that every patient should have one entry, one exit, one record, and one health program. And that is actually possible. It could actually make a difference and actually be a game changer. So all these things are really dependent on the ICT. We think this conference actually provides us with a great opportunity to change the health system as it is and leapfrog the health system and achieve what the president has actually put as the Pakisa for the healthcare system. Thank you.
Thank you very much, Dr. Mbengashe. And I'm going to allow Dr. Kamlashe to speak right after you. I'm sure, ladies and gentlemen, you can see that there is another panelist that is joining us on your screens. His name is Ernest Dako. He's the director of Broadridge. Ernest, can you see us?
Yes.
Okay, he's lifting his hand. I think that's an indication that he can see us. I hope that he can be audible at some stage when we give him time to be able to speak to us.
Thank you.
Hello, Ernest.
Hello. I don't know if you can hear me. Good morning, everybody.
Okay. At least we can be able to see you and we can be able to hear you. We'll give you some time for you to be able to participate in the discussion. And I'm quite well aware that you've been briefed in terms of what we are engaging on today.
Yes.
I'm also quite well aware that some of my audience would be hoping that you were female, but unfortunately you look very much like male. He missed that. Dr. Kamlash, you deal with patients. You don't deal with Internet of Things. You deal with patients.
Do you have a mic?
The sound is failing us. Switch it off. Yes. Yes.
Cut it. Cut the guy.
Thank you very much, Program Director. I must also greet having listened to the last presentation in particular, are asking themselves difficult questions. Where does that 361 billion rand goes to? It largely goes to where I work in hospitals, because the outcomes in the country apparently are not exciting you. Therefore, if they're not exciting you, they won't excite my SG, as it has been mentioned. And I just want us to go back a little bit to what the actual impact that ICT now seems to be making and may make in terms of reducing costs in healthcare. Number one, hospitals and towns were built for poor people. Rich people were treated in their homes. They still are treated in their homes in many cases. Poor people had to be put in one area so that some scarce resources could be shared to treat them. Towns were created for labor reserves. Rich people stay in rural areas, and I think it still is in Eastern Cape, because I've not seen anyone in Boniton and Nauru, where I stay, who even owns a cow or a sheep. Therefore, they are poor in the context of that.
and then go and join another queue for 3 hours to go and see a doctor. And by the time you get to that doctor, you get told that actually you need to come back the following day. And that's the reality of public health in some of our facilities. But in essence, the reality of the discussion that we're having here today is that you're saying we have 843 health facilities. That is hospitals, that is clinics, and so on and so forth. And we have 608 million population. And I'm sure that people like Neotel would want to then provide a solution in essence to respond to that. 6.8 million population instead of we're not going to go into that. It's 6.8. We'll stick to 6.8. That's our reality. Mr. Napagade, I'm going to give you your 5 minutes to make your input. All we're doing is that we're having a conversation towards finding solutions to improve our public health system and make use of technology to make this a reality. And indeed, I'm hoping that next time, Mr. Mfuleni, we have these sessions, we bring with innovative procurement specialists who are going to take these solutions and not tell us that we need to go to tender after having all of these brilliant discussions.
Good morning. Good morning. All protocol observed. That's what my son always do when he doesn't want to go through everything else. So just to put a lighter note on a serious matter like health, there are 2 ICUs that are involved in the health facilities. One can be addressed easily with technology and ICT, but the other one cannot. So I'll tackle the first one. The first part that we can revolutionize and change in the health sector is the hospital gown, because it, it, it defines now the ICU, because when you see at the back, you see the revealing part of it. So if they can start there by innovating and changing the hospital gown, it will be a plus. That was supposed to be a joke. Okay. Another one, I think the Deputy Minister also mentioned to the fact that we are in different levels of understanding of technology and the use of technology. Over the weekend, we were in a wedding, and one of my cousins is a teacher, and then we asked her why she is not on WhatsApp. And he said, you know what, Temba, I'm just waiting for me to have enough money in December to upgrade my phone. Because every time I try to go to WhatsApp, it says the application needs to be upgraded, which was also a misunderstanding of the technology, that he only needed to upgrade the app that is on the phone, not upgrade the phone and go and buy a new one. Going back again to the same analogy of WhatsApp, a very close relative of mine, about 3 to 4 weeks back, we were sent a message that his high blood pressure was quite high. So, not knowing what to do, 1,200 kilometers from the situation, because I'm based in Pretoria, I quickly looked at the numbers that I was given, and I was able to Google some information about it and verify it with a medical friend of mine. And then we were able to send some information back to say, you know what, this is quite high. So this person really needs to manage their high blood level. Here are the sets of food that you must right away start eating. Here is a list of all the food that you must just take away, that you must not even come closer to eating. And at that time, he was still waiting for the test. You alluded to how he gets to the test. He goes first and finds the file and then goes and see the doctor and then gets sent to the testing of the blood, and then they say come back in 2 weeks time, whereas the high blood was quite high at that time. So we're dealing with a lot of challenges. So all these things need practical approach to that. Uput Viana next to me has alluded to a lot of things that I would have said. So if I didn't have my presentation there, you guys would not believe that, most of the stuff that I wanted to talk to you about, he has covered, but I will not repeat them. But what I would like to just emphasize is the fact that, if we can, the challenges that we saw is that more the government regulation, the interoperability that is not there, where the facilities are not well connected to each other. Some of them are not connected at all. The kind of scalability that that can bring about the cost of technology in these health facilities is not there, because each one or each and every province is buying on its own budget, and national is probably also buying and choosing their own suppliers as well. Whereas when they can have the economies of scale, buying in bulk, and be able to negotiate a very long-term approach rather than just what we have in the budget in the next 2 years. But looking at the demand, I think someone has alluded to that, that if that was transparent to see what is it that we're going to have or need in the next 10 years, we can negotiate on that basis, not negotiate on the basis of what we currently want to connect 20 schools or want to connect 50 clinics. So all these things, they require us to be innovative. In Econet, in Neotel, we've been quite known in the industry for innovation. We were the first people to bring about a lot of certain type of technologies. The way we've been able to be flexible in how we build for those. Like we were the first one to have a use. Things that we need to do in each and every sector, or focus in each and every sector, that we can be able to have localized innovation that will be able to drive and bring about solutions that are localized, unlike taking a software from America and try to customize it to our environment, and we end up having a high cost on that. And the last one is innovative finance models that will sustain the public-private partnership. Not only just how we do it now, so that we can be able, when we have that visibility of the 10-year, the 5-year, the 15 years, you are able now to bring those technologies at a level where you don't have to ask government or health department for cost, or rather cost of implementing, which is capital. You come in an operational OPEX mode, because you can see and you can get a better commitment for long-term periods. Thank you.
I think the whole aspect of integration is something that obviously needs a whole lot more engagement, and I hear that Neotel is bringing that up. in terms of how we can better leverage on integration and a number of other things. Dr. Mbengashe, at some point I'm going to come back to you because the one decision that we, or rather the one of the key outcomes that we need to, as a closure rather of this discussion that we're having now, is probably a reflection on what urgent decisions ought to be made in terms of improving patient outcomes. Uh, Once we've had this discussion and reflected, I would want to get a sense in terms of, from a provincial Department of Health perspective going forward, are we just going to continue to talk about these things? Or rather, where do we make a start? It's quite interesting that you brought with now the CEO of Cecilia Makiwane and the kind of language that he speaks, and I'm sure is basically building some appetite in the room around embracing innovation and what kind of things we can actually really do in our public healthcare facilities to be able to improve things from a real perspective. So we move from a summit direct into implementation, and we can come back to a summit and say, once we had reflected on terms of how we have improved public health care, this is indeed what then has been done since. But that is much later. I thought probably let me just drop that to you, whilst we would want to listen to Mr. Jacques Deforce. He comes from Mezzanine, where my understanding of Mezzanine is surely not the one that we're going to be speaking about today. But I would want to gather that you one of the pioneers around M-Health and some of the aspects that that we're speaking about in terms of ICT. You've got your 5 minutes.
Thank you, Program Director. Honorable Deputy Minister, HOD, ladies and gentlemen. As the Program Director, yes, Mezzanine is a Vodacom subsidiary company, and we support the development of vertical solutions, and one of the focus verticals is healthcare. So we've been developing e-health, m-health, ICT for health solutions for the last 6 to 7 years. And I would like to reflect on a couple of the comments that was made by the earlier speakers, and maybe address one or two of the key challenges that was highlighted by Vuyani in the opening address. But I think the word that's important to use is, to the HOD's introduction, is the word enabling. The role of ICT will always remain the role of enabling more accessible health services, better quality health services, enable a more productive, more efficient, more effective health service delivery mechanism. Technology should never replace the human element of delivering healthcare services. We always refer to high tech and high touch. The high tech are not supposed to replace the high touch. The high tech is there to enable and support and make the high touch component more accessible and provide better quality services to our citizens. So I think one of the key challenges that we believe ICT can play an enabling role is supporting the re-engineering of primary healthcare. One of the key principles of decentralizing our services in order to make our services more accessible. A and B, to move away from a curative model to a preventative model. Preventative health services should be delivered in our communities, in our schools, at our workplaces, in our homes. And this is where we see mobile as a key enabler. In order to assure quality of services in our homes, in our schools, at our workplaces, mobile can fulfill the role of making data and information available that currently reside in a hospital environment or in a clinic environment. So I think the challenge there is not a technology challenge. And the HOD also mentioned earlier, the discussion should not be led by the technology providers. The discussion needs to be led by the service providers, the healthcare service providers, the beneficiaries of our health service industry. And it's to this effect that we believe that the only outstanding item is really the financing of these services. I'm not concerned about the technology. We know it can be done. We've got several successful implementations, scaled implementations in several African countries. Some of them working in more than 5,000 clinics, delivering primary healthcare services. That the technology are not the inhibiting factor here. The inhibiting factor to progress to more sustainable, more scalable implementations are really the funding mechanisms behind these services. So we need to work towards ways in which we can support the introduction of these services, both in public and private sector. So look at medical schemes. Are there reimbursement codes for introducing screening or supporting screening mechanisms for early diagnosis of certain diseases? Today, there's no reimbursement tools for ICT-enabled screening services. We need these reimbursement codes in order for private sector to invest in developing capabilities that allow early screening of diseases. So again, moving away from curative to a preventative model, technology can enable the early detection of diseases, managing the health risks that reside within our communities, within our households. But we need the funding mechanisms to be put in place in order to support these services. The same can be extrapolated to public sector and say within government, what portion of budget do we allocate to the ICT component within healthcare as an enabler? Now, this is where we need to take accountability as technology providers in acknowledging that one of the most significant contributors to health inflation globally is health technology. Now, this is not only true for Africa and for South Africa, this is a global phenomenon. So can we justify investing $20 million in implementing an ICT-enabled system in order to make health services more accessible? So this is where we need to put down a baseline and say, these are the metrics that we as government, as we as service providers will use in order to evaluate whether your ICT-enabled intervention is justifiable, whether it's something that needs to be deployed across all health facilities in South Africa. And those are the metrics that industry will then take and say, we will deliver on these metrics, and we will show that there's a return on investment in introducing ICT services in our healthcare industry. As I've said, the technology is not the limiting factor. We've got great solutions. We've got local service providers, local solution providers in South Africa that can provide these services, that can provide these solutions. But we need to create a conducive environment for these service providers to operate in. And I think that is one of the key challenges that need to be addressed by both public and private sector. Thank you, Mr. Program Director.
Thank you, Jacques. Fundile next to you is somehow one of the guys that I was actually speaking about. And I'm going to allow himself to put himself on the spot and quickly introduce and as well as have his input. And he's got 4 minutes.
Thank you, Program Director. Let me greet the Honorable Deputy Minister, and let me acknowledge my HOD here. I'm here to support my HOD, and my name is Fundile Gebrumedin. I am working for the Eastern Cape Department of Health. I do health technology and I live health technology. There is a component of health technology that is clinical engineering, which focuses on medical devices. That is the element that provides input into the softwares. It's probably, you would say, the transducers that were shown. There was a slide here that showed transducers, how you pick up a signal from the human body and then you process it so that it provides accurate and credible data for the clinician to interpret. So that is an element or a system that forms part of this discussion, because there is the hardware and there is the software. And then we are sitting here discussing the technology from an ICT perspective, obviously creating that enabling environment. But the interesting fact about health technologies is that they are not limited only to the physical equipment or the software. Even people are technologies. In a health facility, the clean room environment is a technology. When you go into a theater, and you are not exposed to any airborne infections. That is a technology in itself. So when we discuss the health technology scope, you might go into a hospital, you've got a good ICT system, you've got a good equipment, but the environment that you are treated under also plays a major impact. So when we measure the quality of services or healthcare service that we are providing, we cannot provide it partially. It has to be a full solution that focuses on all the enabling factors in a health facility. So in this discussion, there is an interest, or my special interest is that technology must not create a problem, because yes, it has got a good intention. When you introduce it, you've got good intentions, but then it carries an unintended impact. Acknowledging the environment, I think we discussed the environmental factors, we talked about the socio-economic factors, but then there's also the technological factors. In South Africa, it's been discussed over the past presentations that we do not manufacture a lot of technologies, we import technologies. And that in itself, in the medical space or the healthcare space, it is an obstruction, okay? It's an obstruction to progress, because those devices need to be maintained. You need to buy consumables, you need to buy accessories to support those devices. Actually, the money that you spend on the capital cost is limited compared to the money that you spend throughout the life cycle. That's why on the funding model, we are seeing that that cost is escalating, because as we produce more devices, they come with more consumables. We're moving into more disposable devices rather than reusable devices, because we're trying to introduce infection control protocols. So it will always escalate the funding that is required to provide healthcare. But to be short, the discussion on mHealth is focusing on mainly diagnosis. There is the diagnostic equipment that we use to pick up signal from patients, but then there's the monitoring devices where you continuously monitor devices. But within the diagnostic devices, there is imaging equipment. And I think ICT needs to take cognizance of the image sizes that are produced by those imaging equipment. For instance, the safe methods of producing images, ultrasound and mammo, because you don't use a lot of radiation, it's not the traditional X-rays. The image the image size can be up to 180 megabytes. How do you then take that image from one point to another through the current bandwidth? The bandwidth cannot carry that. So these are the issues that we need to focus on to create that enabling environment. Simple X-rays or general X-rays, they produce up to 16 megabytes. How do you take that through from one point to another, where you're providing, or you've got a radiologist at one point, and in one point you only have got the equipment. So we need to discuss those issues, because I think the diagnosis part, there is that minimum information that you can carry, but there is that critical decision-making information. You cannot make a clinical decision if you don't have the proper images or the right images. And if you compress those images, by the way, you compromise in quality, and the doctor on the other side or the physician on the other side will be working on misinterpreted information, or information that could probably lead to medical legal claim, or you would kill the patient. So these are the things that we must consider, because there is the software that is linked to the devices, and there's a software that is administrative. And I think we need to discuss all those. Thank you very much.
At least we're getting closer to solutions. But Vian,
Yeah, thank you very
you're
much.
saying the future is, how you define it, is the next, what, generation of health?
Yeah.
And you talk about telemedicine. I want to just, for you to quickly just touch on that, and then we can give over to
So,
Dr. Mariashi.
thanks a lot. I think from our side, what we're calling for, we're saying there are challenges on the ground. There are technology solutions that are evolving very fast. there are challenges around how you carry data from one point to another. There are compression algorithms that are developed to reproduce the image on the other side almost seamlessly. And of course, these are issues where you start to deal with clinical risks. I think what's important though is for us when you have those discussions, is to say, what are the alternatives? Because we're dealing with the technology that's dealing with development issues. We're saying, whereas you have a clinic at Ndane that has got no chance of getting a better view of what's happening because there's no clinical professional there other than maybe a nurse or a community health worker. What then the technology does, it intervenes, it says, I will bring you some view of what's happening to a person who sits in East London. So we're talking about an intervention that says, whereas today you've got nothing. So whereas a pregnant woman, Etendane, will be assessed through urine test, a bit of a blood pressure, and but today we're saying actually the vital signs of the baby inside the stomach can be captured right into the rural village of Tendana and be shot through to a professional here and have an early warning signal. And we can have a discussion about all the constraints, which is important discussion to be had. The challenge with Africa is that we get trapped into a perfectionist mode and say, but there is still another mile to go. But where we are, we're not standing on a very good platform. Our push is to say, these solutions have high efficacy. They are being used in America, they are being used in Europe, but Africa needs them most. What is lacking is boldness, is vision that says, you don't need new money to do these things. It's about how you reorganize your budget to deliver healthcare. So the answers are there, the technology is there. Our push point is to say, let's push, let's move forward, let's advance the thing. Some of the things will perfect them to get to better compression rates, seamless, better bandwidth down the line. But today you've got compression algorithms that do this, that produce, that takes X-rays from one point to another to be interpreted by a radiographer seamlessly with low bandwidth solutions. All these things are embedded today. Program Director, my ask for South Africa and Africa is boldness of vision. We talk about these things, they become nice stories that we put there, but we remain with problems and challenges. Healthcare budgets expand every day. Health outcomes are not improving significantly, but there's investment in technology that the US is benefiting. They need it less than us, actually. We need it more. We need to be bold and move forward. Mobile is a DNA in Africa, so we should be leveraging it a little bit more. Last comment I want to make, in parallel to this, if you look at the mobile payments domain discussion, it's exactly the same problem. Kenya developed mobile payments, and it becomes a gold standard for East Africa. But every country is fiddling, saying, okay, I want my own payments. The Reserve Bank governors are not sitting to discuss and say, how do we make an M-Pesa to be network neutral, to be able to compete with Visa and MasterCard? It becomes a Visa and MasterCard of Africa. I think in the M-Health, we have a chance to do that, but it's going to need boldness of vision. So that's my closing comments.
I'm a firm believer that summits are, or rather should be different to indabas. It can't just be about a discussion. It can't just be about a conversation. When you summit, you should at least have a minimum program that you take from summit and right into implementation. We've got the right, I think, set of partners that are sitting here. And in essence, we're having a discussion around a solution. Dr. Menashe, to close, boldness of vision.
Yeah.
What is it that is a minimum program that we can take from this? And what it is that we can just, when we live here, we know that this is the minimum package that we can not just engage, but move closer to implementation. Especially if we're saying, well, it's a Vodacom analysis that we don't need new money. I'm not exactly sure how much of a further analysis has gone into that budget to actually make that statement. But if Treasury was telling me that, I would probably, better believe it. But Vodacom is telling me that we don't need new money. Dr. Bengash, the floor is yours.
Yeah. No, thank you. And I think, I mean, I must just really thank the insights from the other panelists. I'm just going to frame this in a very simple way. I think the Deputy Minister has been in the province and has been really promoting one essential component of what this summit should support: the broadening and the building of a very reliable broadband infrastructure for health, education, and e-government. I think if we can get that in the system, we'll have a long way. I think the second one is that it's really the broadening of the relationship between government, business, and the people of the Eastern Cape. I think it's absolutely very important that we should re-look in the manner of how we interface and how we interact, so that all solutions are actually guided by a common vision of achieving the objectives that are actually either defined in the NDP or in the provincial strategies. So that's the second part. I think the third area, which is absolutely very important, it is the people that makes the change. Technologies only support the people. So it is very important that all of us should be grounded on what the people require and how we can enhance human and development, actually achieving those things that human beings actually require. I think the technologies for data are very important, but they must be seen in the perspective of human beings. The processes and the technologies that support the processes and how we do work must actually achieve how people do work better and achieve better results and are being more productive. I think we must actually make sure that we're creating systems that are really being able to communicate amongst themselves and able to transmit information in a way that is easy for people like myself, decision makers, to make those decisions much easier. I sit as a head of department with a limited budget. My key issues that really confronts me every day, I have to make a decision about different comparisons about what is it that I can use to achieve better outcomes using less resources and what those costs are and what are the implications for the people of the Eastern Cape. So if we can just get some few things, broaden the connectivities, it creates the opportunities, make sure that businesses work together to provide solutions that assist the province, work with people, provide solutions for people, and let technology support people and make sure that it actually happens. And make, at the end, the patient's experience of healthcare services, whether it's education, interface with government, interface with business and other people, to the best experience. I think if the summit can really try and bring those basic things, we'll be able to achieve much more. Thank you.
I'm so tempted, Deputy Minister, to throw something at you at this point. Whilst we prepare to get Ernest back online, let me do the honors. I'm going to come to you, Deputy Minister, because we're summiting to find solutions. We're not summiting just to have a conversation.
Thank you, Babs. I listen.
I'm here. I don't know if you can hear me. Okay, thank you. Thank you. Can you hear me okay? Can you hear me okay? Okay. Thank you, ladies and gentlemen. The conversation has been extremely informative and stimulating. The comment that I really wanted to focus on was related to the issue of scalability. And I've heard some of the panelists mention, the issues associated with, for example, lack of ICT infrastructure, and therefore that being an impediment. And I think to some extent, yes, some of the status of the infrastructure backbone will be an impediment, but I'd like to give a few examples of just how, even with creativity, we can better maximize the use of the technology capabilities that we have right now. In year 1998, 1999, I was doing a project on improving schools. This was both in the Netherlands and in the United States. And one of the systems that we benchmarked in 1998 and 1999 was Malaysia. And even back then, you could actually go online, see which a school, understand which schools are not performing, and I could log in online and that morning see which children were in the classroom. And this was in 1998, 1999. Now imagine now we're sitting in 2015, and most district managers, for example, could not actually tell you who's at work in their clinics today, or how is that clinic performing a particular indicator, like immunization, let's say measles dose 3. And I say, who are your worst 10 performing clinics? That is the type of work, in fact, we do right now, helping clinics to understand such metrics, and it takes a month or two to get a basic indicator like that. And so what we've been focused on doing is developing systems where within 3 clicks and in a few seconds, a district manager can see that, or a mayor can see that, or a headmaster or somebody in the Ministry of Education could see this is who's performing, how they're performing, and make that be available really, really quickly. And so even if we cannot start with the most advanced of capabilities at the moment, and we will be able to migrate there. I have confidence that we will. We can start with simple things, and I'll just give one illustrative example in closing. One of the provinces where we've done a lot of work has been Western Cape with tuberculosis. And in one of the areas where we work, the distances people have to travel are sometimes in excess of 600 kilometers to visit a clinic. In the program there, after testing people for TB, everybody has to come back for their TB result. And when I asked the district management in that particular district, how many of these TB tests are actually positive? They said maybe somewhere in the range of 5 to 10%. So meaning 90% of these people would have to travel 600 kilometers each way to get a negative result. And I remember one of the panelists earlier in this discussion mentioning the queuing, and you had to queue for all these hours. So 600 kilometers. This was costing people about 700 Rand each way for the journey. To be told your TB result is negative and go back home. And I think we can basically find some very simple initial use cases where on a large scale, we can gain great efficiencies by using simple technology where, for example, you could phone people with a negative result and then curtail the need for them to come in and impact your facility in terms of queuing for something like this where such a small percent of people actually do need a clinic visit when they're traveling such long distances. So I think we can be creative. We don't let the perfect be the enemy of the good, and start with doing some very large-scale impactful things right away to vastly improve the efficiency, but also selectively look at areas where we can have the biggest bang for our buck initially to improve patient outcomes with the technological capabilities that we have now, and keep migrating the complexity as bandwidth and speed and the basic backbone capabilities allow us to do over time. So thank you. That was the main contribution I wanted to make, but I really do feel that, as one of the speakers did say earlier, that given the potential we have to vastly improve either efficiencies or outcomes, hopefully this meeting today is part of demonstrating what's possible, and therefore ensure that we are willing to now overcome the challenges, which often are very overcomable, to be able to actually mine this amazing opportunity that we have in front of us. Thank you.
Offices all around the world. I'm not exactly sure where he was joining us from, but that was his input. I've got a request that there is at least 3 people on our audience that would like to pose a question. And I'll keep it to the 3 that they would want to pose a question to my panel. And the future Dr. Mfuleni wants to lobby on behalf of the people and wants to make that number 5. I see Prof, the CEO of SITA, the right people are talking to. Where's the third hand? So there is no third hand. There is no fourth hand. There is no fifth hand. Ayibikho ke imivuka kule micimbi. Okay. Davungqaba. Ingakusokolisa ke loo nto because it's far from drone technology.
There it is, yeah.
It's a user problem.
Yeah. No, thank you very much. I think Program Director, thank you for giving us I know time is quite limited, but when you meet an august panel like this, you are very tempted to really want to ask questions. I mean, the comments are great, but here's my question, which has a stingtail of a comment at the end. The way in which I think everything that has been said, I agree with. I don't have one issue. It's great initiatives and great perspective of looking at health. What I wanted to put as a question, there's a platform called Kaggle, Kaggle competition, whereby problems, and there are a number of health-related issues there, for instance, that you can find. It's a competition whereby, for instance, you find, let's say, there's one competition I know for sure on how to solve, diabetic-related issues by looking at someone's retina, for instance. Now, the problem is put, people, wherever they are, they put their hat to say they will compete, and the prize is put, and the time is put there to say, you have to solve this problem over, it's almost like what is called an online hackathon. You have to solve this problem in 3 months, and there are judges that will come, and everything is done openly, and the price is there. Similarly, with your patient health records, if, for instance, some of these complex problems, I mean, these guys can hack a health record for you in 2 days on a weekend. I know that. What about modeling, for instance, some of these critical problems? It is not circumventing tenders, but it's out there online, visible to everyone, and the price is there, and people compete for it. And the best developer, the best person who would have developed then would win, for instance, the product. I forgot to say something, Deputy Minister, that it's not only WITS where I graduated that has a master's and PhD. NMMU, you can study computer science and information systems up until PhD and postdoc if you want. So just for you, it's a side issue.
Thank you, sir. Yes.
Thank you. So mine is, I'm a solutions person. Deputy Minister asking for solutions.
Of course.
And I think so it's mostly a comment and perhaps a request that coming out of here, we do something concrete. Number one, so that we, given the current legislative framework, we have to deal with our issues given the legislative framework. How do we get solutions out as quickly as possible? Just to give you an example of where we have come to the party, I think, as SITA, when I mentioned the pod costs have fallen, we have just reduced now, if you want to go from 2 megs to anything, 10 megs, 50 megs, if you want, the average cost per megabit comes down by 50%, sometimes even by 70%. That's a new SITA coming to the party. And what we'd like to do is that we are working with the service providers. We regularly work with Vodacom and Neotel. And so my suggestion is that we form a work group so that we can exploit this very new opportunity, so that we can connect these things outside of OR, right, district. Because OR district has been run from national. What about the other districts? So let's form a work group. We have a team here that is fully resourced that can do the same thing. Just also want to share something that maybe during the break. This is an architecture of all the applications that are being used. And this is a new thing that we've just done. Just to say that we're not talking about a pipe dream. All the applications that are used by the education system, whether it's basic education, higher education and training, and even Umalusi and so on and so forth. We have mapped them out. We'll be mapping out all the databases out there. We'll be mapping out the threads that run through, so that we do indeed have a single view of a learner. We'll map out even we'll map out the learner prior to getting into the education system. Right? Now, the idea there is to create a data warehouse structure. We are not the ones probably geared to then innovate on top of that. But we are talking about the private companies that are then using that data, that is public data, that is packaged in a particular way for the innovation that we're talking about here to happen. Right? Because the data is there, is being loaded each and every day in the government system. Again, part of that work group, in addition to the networks, is then to map out the similar kind of systems for the healthcare environment, and then unleash them into the private sector. Proposal for a solution. Thank you.
Thank you very much. When a proposal comes from an accounting officer, you take it seriously. Dear?
Thank you, Babs. Ebona Ustumo knows how I work. He's been my CEO for a long time. Although I jumped the ship. I want solutions now. We can't be saying the same rhetoric. We know the challenges, all of us. The reason we gathered here is to provide solutions to the challenges that we are facing. That's what we want. We don't want people who lament all the time. Ours is to say, in this policy, there's a gap, and this is what we propose. And then we take that so that we address the challenge. I want to come back to the province maps. As Ustuma has said again, SA Connect talks to national priorities and a pilot phase. Provinces need to come up with their own plans with budgets. We're not asking you to tell us how to implement SA Connected National in those 1 or 2 regions that we have identified. But we want you to tell us, as the province, what is it that you are going to do? Because that talks clearly to the provincial growth. What is your plan? Of course, it has to be aligned to what SA Connect is about. And you cannot just have a plan that is not costed. That is why we are emphasizing the fact that it must not only be a government plan, because the industry will not come on board if you just sit down and say this is what we are going to do and this is how things are going to be done. It's gonna take you a lot of time and we won't be able, because the muscle we don't have. I want a commitment here, I'm very clear, simply because this is driven from EXAC, which is under the Premier's office. Government in this province must be clear, they are going to make this a priority. That Pagisa that we're talking about must include this so that when MEC Somio goes there to say this is the budget allocation, it incorporates this as part of that. So that we say private sector come on board. I know, of course, they're already complaining, telecom, of which even there, what we said was that telecom is the lead agency. We didn't say telecom is going to do everything, which helps them now at this level to say we see what national has done. But as the province, this is how we are going to complement the work that is being done by national, working with these stakeholders that are here, so that they come and say, I know FiberCo can say we'll come and put in some cables here and there, Vodacom will say we'll have infrastructure there we can beef up, and everybody else can come on board. Province must take lead. Province must not fold arms and wait for national. No. Otherwise, we are not going to move. I said earlier when I spoke, other provinces have taken the initiative, including Mpumalanga, as small as it is. Mpumalanga has a clear plan that is budgeted for. They say on top of what national has tried to give to us, but this is what you are going to do to address the needs of the people of our province, because they understand they cannot only wait for national. The province, again, must take us serious as the people of this industry now. Pat, thank you.
Thank you. Thanks, Program Director. I think another area that we must not really underestimate, even if we talk about accelerometers and all kinds of technology gadgets, is the importance of leadership. Thanks, DM. And I'm sure you're not comfortable with talking theory here. I'm sure you're not grasping that, look, this is where we want to go. Rest assured, in Eastern Cape, in my department, I have a leader next to me who loves innovation. And as we're sitting here, action is happening in Eastern Cape Department of Health. We are now be inviting you very soon to the switching on or opening of the first paperless hospital in the country. It's going to be in Tanzania. So, a lot of work has been underway, and a lot of it has not been technology, it has been change management. There are projects right now, as we're sitting here, that we can demonstrate to you that if you come from the biggest clinic in Tanzania, Nonkekambo, and you're going to Cecilia Makiwane, you will actually be registered at your clinic in Nonkekambo now as we're sitting here. It's happening while we're sitting here. And you will not wait, you will not take more than 3 hours if you come from that clinic to get a full service at Cecilia Makiwane. It is happening as we're speaking. Secondly, we have a project in Victoria Hospital. It's a hospital we're supporting that is remote from a specialist center. We will be demonstrating to you now, it's just a matter of formalities and giving that report to SG, that we have managed
to reduce the waiting times of people coming from that area by 80%, because now we have a video link that has been set up to that hospital. We have a teleradiology system that has reduced my printing cost in X-ray by 2.8 million. That is happening. In January, in the same department of Dr. Mbengash, we're inviting you in January. You know that in Eastern Cape, even if you have a medical aid, actually in South Africa, you may wait for 6 months to see a dermatologist. Most ladies know that, you know. I know it's more than 6 months to wait to see a dermatologist. In January, we're switching on in Idujwa CHC, a teledermatology clinic. People from the villages who don't have medical aids will be able to see a dermatology within 7 days, even if they don't have medical aids. That work is now being finalized. So it was all about leadership and collaboration and support, actually, I must say, from other people who are in the room. You know, and some ICT players, they have played a big role in making that happen. It is happening. The most important part, DM, is that with those savings, which I think is what most people are aware, we're not really saying we're reducing cost. We're containing costs. With the 2.8 million that we're saving, we will be able to provide a welcome snack for a patient that has been in a PTV, a transport, for 6 hours to come to CMH. So with that money, we're going to be able to buy them a welcome snack for breakfast when they get to CMH. So there's a lot of value that comes with it. So there is something happening. Just be comfortable. 2016 is going to be a year for you and SG. It's coming. Thank you.
Just a bit. Okay, it's on now. Look, I think the CEO has nailed the thing. This thing is about leadership. It's about leadership. Leadership is about having sharing an inspired vision, making decisions under uncertainty, but being bold to marshal your teams to see it through. And often when there's uncertainty, people shy away from making decisions and we remain in a quagmire. Actually, you have no choice. The platform is burning already. So we're saying industry, public sector, civic society, there must be leadership in every level to see these things through. And I like what the CEO of CITA is saying, to say, let's agree to take practical steps forward. We are in the private sector, and we throw no bones about it that we are commercial. However, we spend a lot of R&D focusing on social issues. How, if you sit on top of a company like Vodacom with huge balance sheets, it would be an indictment if I would not look and say, how do I repurpose this investment to address social? We could simply be talking data. I think the CEO did say, I don't just want data and voice, and he wants to say, how do you solve my issues? We could simply be doing that. It's probably easier. But we are not saying to government, we think we're going to invest in health, we think we're going to invest in the next generation policing vehicle, will you buy it? We go and invest and demonstrate it works. This is the thing. And this is about leadership. How you take the asset of the nation, whether it's in private hands, and repurpose that investment to deal with social issues. The challenge we normally have in South Africa in particular is that even though the solutions are there, it continues to bubble. I will make the last point and say, if you look at the Americans, what the Americans do, they take their technology baked at home, they stay with it, they move, they embrace it until it becomes gold standard. They export it across the world. With us, we sit and bubble and say, yeah, we see it's there, but maybe Umadibu Neyake on the other side. So what do we do? So we take the thing and move forward, even if it's for Madiba, and then deal with the issues that we want to execute on. For me, the leadership thing is very important thing. I also want to say every year there's a World Telecommunications Day. What I see always, the celebrations, is what Professor Ngaba set up, the ICT centers, the whole thing, the community centers. It's so monotonous that we celebrate the same thing. Can we not celebrate a large-scale implementation of e-health in May 2016 as a big World Telecommunications Day project That talks to commitment we have to make from industry. And I'm not necessarily saying government must buy from me. I just want to say it's there. If other people have got it, take it from them, but make progress for the country. That's the issue. I'm not saying come and buy it from Vodacom, therefore we want to be monopolistic. We're saying we demonstrate it works. If somebody else has got it, make progress, buy it from that person to make progress. I hope you'll choose me, but if you don't choose me, the country will still make progress, right?
Ladies and gentlemen, it's been a mind-boggling, I think, engaging session that we've had. It was only supposed to last 1 hour, and I'm sure some of you have even forgotten that you were supposed to have lunch. But let me not be the one that is standing between you and lunch. We do have a minimum program coming out of this panel that we are going to put into execution, and we've already now, at least we can safely say that we'll take SITA as a vehicle that will be able to take us forward and be able to make sure that these things become a reality. DM, you've got my commitment. Enough said.